Welcome, Dr. Sammons. Thank you so much for joining us. Oh, and your cat, even better. Matches your outfit too. That's perfect. Very well planned. We're so excited to hear from you, so I will let you jump right into your presentation.
Great. Hello, everybody. Happy to be here. This is Possum in my lap. I'm working from home today, and she is very excited to talk about the right dose, managing treatment and side effects. So just to tell you a little bit about me, I'm a breast oncologist, currently at Dana-Farber in Boston, Massachusetts. I saw some folks from North Carolina. I was at Duke for 7 years prior. I treat women with all stages of breast cancer. This is an incredibly important conversation. I think, we could talk about side effect management, and dosing for hours. Today is going to talk a lot about dosing and dose reductions and how dose reductions might impact side effects. But then at the end in the Q&A, we can talk a little bit more about specific questions about side effect management that you might have outside of dose reductions. And maybe we'll have to have even another session about just managing different types of side effects. So today we're going to talk about the dosing of breast cancer medications, both in the early stage and advanced stage. And we'll talk about, just educate you a little bit on how physicians and companies decide what dose patients should get, usually starting in the advanced or metastatic setting, which then that dose generally moves into the early stage setting. And then we're going to talk a lot about what I hear about in clinic. There's no question that dose reduction can help with side effects. There's just absolutely no question about that. But a lot of times my patients want to say, okay, well, but if I dose reduce, is that going to impact my outcome? Is that either going to impact my chance of cure or my chance of this therapy working for a longer period of time? And so we're going to go over a lot of that data too, because I think it's just important to educate you so that you can bring this back and talk to your teams. So in terms of an introduction, the dose of a medication is obviously how much of that medication that you take, either whether that's oral, whether that's injection, whether that's intravenous chemotherapy. It's also how often you get it. So maybe you take the drug every day. Maybe you take it 3 weeks on, 1 week off. Maybe you come in for IV infusions weekly or every 3 weeks. And dosing also has to do with how long you take it. So in the early stage breast cancer setting, generally we're using therapies for a finite period of time. If it's HER2 targeted therapy, we give that for a year. If it's endocrine therapy, you might be on that for 5 or 10 years. But in the advanced setting, we generally give therapies for as long as they're working. And sometimes, fortunately for most patients, that could even be years. And so that's where tolerability and dosing really, really gets tricky and is hard for patients. The goal, whether it's early stage or advanced stage breast cancer, is to maximize your outcome. If it's early stage, we want to increase your chance of cure. If it's advanced stage, we want to prolong the amount of time that you're going to be on that medication until the cancer grows, and we want to prolong your life for absolutely as long as possible. That's the goal for the vast majority of people. Some people have different goals, which are quality of life only based. The goals are also always to try to minimize side effect profiles, and we try to do that as best as we can within the confines of what we can do and what's safe. The right dose is the one that you can stay safely on and consistently. And so I can't say that enough. A colleague of mine once said, you simply can't benefit from a drug that you don't take. We would rather reduce the dose of a drug and keep you on it than have you just completely stop early because your side effects were so bad that you just, threw the baby out with the bathwater and said, I can't do this anymore. So how do we determine the dose? Most drugs are studied for the first time in the metastatic setting. That's not to say, that's changing a little bit. There are some trials that do phase 1 dosing in in the early stage, but it's much more common in the advanced setting to study new drugs. There's more patients looking for trials. It's considered a little bit safer. And generally, the way we study a dose is the scientists who study these drugs in animals, so usually mouse models, and then sadly, because I'm obviously an animal lover, we generally put the drugs into larger animal models too, like monkey or dog, just to look at side effects. And based on the PKs, PDs, efficacy that they see in the animal models, then they determine, what dose would be the right dose to start in human studies. And then we start at that dose in the phase 1, and then you usually treat, 3 to 6 patients at that dose. You monitor them for side effects, and if the side effects are not too bad, meaning they don't have any dose-limiting toxicities, then they go up to the next dose. And they do that until they reach a dose that has too many DLTs, and basically too many side effects. So they escalate it until they see side effects. And then that's what gets you to your maximum tolerated dose. And then historically, we use the maximum tolerated dose as the dose. But now with newer pathways, we're trying to get to the dose lower than the maximum tolerated dose, more the dose that's the most efficacious for patients with the most manageable side effect profile. But that's really a change that has occurred in the last 5 years or so, really through the advocacy from groups like LBBC and patient advocates. And what's true is that the optimal dose for your cancer might not be the maximum tolerated dose, and more is not always better. And so new initiatives are really trying to push that. So Janice will probably talk to you a little bit about this later, but her and many patient advocates have been involved in this movement called The Right Dose. You can go to therightdose.org, and it's been a patient-centered dosing initiative where patients had said, hey, wait, I don't want to go to the dose that has the most side effects. I want to go to the dose that is going to work for my cancer but have less side effects. They did a survey of 1,200 metastatic breast cancer patients in 2020, and 82% of patients who had dose reductions reported meaningful relief in their symptoms. So dose reductions do work to provide relief of symptoms, and the majority of patients supported flexible dosing discussions. There's going to be a more antibody drug conjugate focused survey that's going to be coming out soon that maybe Janice can talk to us about. Interestingly, in this survey, in the 2025 updated survey key findings, 82% of patients experienced a bad side effect to medications. So this is just so common for all breast cancer patients. 72% started, or 17% started on a lower dose. Their oncologist said, hey, I'm worried about how the high dose might perform for you. Let's start at a lower dose. 94% started at the recommended dosing frequency, meaning, you're supposed to take it every 3 weeks. You took it every 3 weeks. 35% reduced the dose after starting at the recommended dose. That's 1 in 3 patients needed a dose reduction. And the reasons for the dose reduction were generally half of patients had a bad side effect, 35% had concerns about side effects, 5% had other health problems, and 50% reduced the dose for other reasons. Now, because of advocates like you all on the line and Janice and many others, the FDA has really heard the concerns of everyone. And several years ago, they started an initiative called Project Optimus. And, I will say that when you want to tell thousands of pharmaceutical and biotech companies what to do, it really has to start with the regulators, because drug companies are going to want to push the dose with the highest chance of getting their drug approved, because they spend millions, sometimes billions of dollars by the time they get into a trial. So it really needs to come from a regulator standpoint. And so I'm glad that the FDA did this. The goal of Project Optimus is to shift from the highest tolerable dose to the optimal dose. And it encourages randomized dose finding. So once you get up to that maximum tolerated dose, they are now requiring companies to study the lower dose too, so the maximum tolerated and the lower dose for efficacy, because so then that way they can determine maybe the lower dose is just fine, and that's what can be moved into phase 3 trials. They also had the goal of focusing on long-term tolerability. A lot of times the safety of drugs is just studied in the first month. And as you all know, side effects can happen at any time, years later. And they're requiring multiple dose studies. So for new drugs moving forward, there's going to be clearer dose guidance, hopefully leading to better quality of life without losing effectiveness for patients. And I just wanted to give an example of success. This camizestrant is an oral SERD that is an oral, basically, form of fulvestrant that's being studied in the metastatic setting. This was their phase 2 trial where, based on Project Optimus, they looked at 75 milligrams of camizestrant and 150 milligrams of camizestrant. 75 is in the light blue, 150 is in the dark blue. You can see there was no difference in efficacy for twice the dose. And based on this, they moved 75 milligrams into the phase 3 study. And so this is just an example of hope. I hope for everyone on the line that moving forward, more elegant dosing studies would have been done. 5 years ago, they only would have studied 150. We never would have known that 75 was good enough and had better side effect profile and could move that into phase 3 trials for approval. And so let's talk a little bit about dose reductions in early stage breast cancer. Dose reductions are obviously when you come into the doctor and you say, hey, I'm having a lot of these side effects. And your doctor might say, okay, that's pretty significant. Maybe we should reduce the dose. Now, I will say that dose reductions in early stage breast cancer and metastatic breast cancer are a little bit different. Dose reductions are a little less common in early stage breast cancer. And it also depends on what we're talking about, whether we're talking about oral therapies or chemotherapies. In early stage breast cancer, the treatment duration is shorter. Oftentimes chemotherapy is 4 to 5 months. Whereas in metastatic breast cancer, treatment can be a lot longer than that, and side effects are generally more challenging. In the early stage setting, doctors also might feel the need to treat the patient very aggressively despite side effects because they're shooting for cure. And it is, regimens are based off of metastatic breast cancer dosing. It's pretty rare for companies to change the dose in the early stage setting, though I will say that they did just do that with ribociclib or Kisqali. The metastatic dose is 600 milligrams and the early stage dose is 400 milligrams. So, we are seeing some evolution there as well. There's not as much data in early stage breast cancer to support dose reductions, but we will talk about a little bit of data. So some reasons for a dose reduction. Let's first talk about chemotherapy. So probably the most common chemotherapy that we give in early stage breast cancer is dose-dense adriamycin with a taxane. So paclitaxel, nab-paclitaxel, or docetaxel. Taxanes have very significant neuropathy risk, and dose reductions can be very, very helpful in reducing the neuropathy, but also making sure that the neuropathy is not a lifelong problem. Sometimes we run into issues with nausea and diarrhea. Usually that can be controlled with supportive medications. If we can give supportive medications like anti-nausea treatments or anti-diarrhea treatments, and that helps without us having to reduce the dose, we prefer that. But if we're optimizing all of the anti-nausea medicines or anti-diarrhea medicines that we can give you and you're still struggling, then that would be, a potential indication for a dose reduction. Certainly, if a patient is having interference with their activities of daily living, I've had patients come in after a dose of chemotherapy and say, Dr. Sammons, I was not up off the couch for more than an hour a day. That's not okay. So really talking to your doctor about, if your chemotherapy is rendering you on the couch 90% of the time, unable to cook, unable to clean, unable to do the daily things that you need to be doing, that's something that you need to tell your team about, because it could be an indication for a dose reduction, but also making sure that there's nothing else going on. Certainly in the setting of dangerous medical situations like neutropenia, that's when your white blood cell count is very low and you're at risk for infection. Severe anemia, severe thrombocytopenia could be indications to reduce the dose. And then there's other serious medical conditions like interstitial lung disease that can happen as well. So we know that dose reductions lead to better tolerance. There's really not a question about that. But how do dose reductions impact outcomes in early stage breast cancer? Well, I'm going to start with chemotherapy in early stage breast cancer. There was this pretty big study of 1,300 women that was done by the Canadians a couple of years ago, and they looked at patients with stage 1 through 3 hormone receptor positive, HER2 negative breast cancer who basically got adriamycin, taxane, Cytoxan-based regimen. And they saw that if patients needed a dose reduction and they got less than 85% of the intended dose in the first 6 cycles, that outcomes were slightly less. Patients were a little bit more likely to recur in the early stage setting if they needed a dose reduction in cycles 1 through 6. Now, that's not to say that if you're having severe side effects, that your doctor should not dose reduce. Sometimes we have to dose reduce to get you through the treatment. But this is one of the reasons why doctors in the early stage setting really try to maximize, in terms of chemotherapy, your supportive medications and try to keep you at the same dose before dose reducing. However, if you're having severe side effects, that is very important. And if dose reduction is needed, then we absolutely still do it. Now, alternatively, for patients with high risk hormone receptor positive, HER2 negative breast cancer, we now have approval of abemaciclib or Verzenio added to endocrine therapy in the first 2 years. This is really for lymph node positive patients, 4 or more greater nodes, T3 tumors, grade 3 tumors that are node positive. So, a higher risk population. Abemaciclib does reduce the risk of recurrence by about 8%, and it does improve overall survival. In the Monarch E study, which looked at this, they did look at the impact of dose reductions on recurrence risk. And what they saw was that 50% of patients, 1 in 2, needed a dose reduction of Verzenio. I don't know if anybody on the lines had Verzenio, but the main side effect is diarrhea, and it cannot be pretty sometimes. So half the patients needed a dose reduction. But the amazing news was if you needed a dose reduction, even a substantial dose reduction, there was no difference in outcomes. And so this data has made me feel very, very comfortable that for my patients on Verzenio, or really any of the other CDK4/6 inhibitors in the early or late stage setting, dose reduction really does not impact outcomes. And I think that that is very good news for our patients. And so if you're in the crowd on Verzenio and your doctor has been telling you, you know what, a dose reduction would really help your side effects like diarrhea, nausea, loss of appetite, just know that we have very good data that it would not impact your outcome, which I think is good news. A colleague of mine, Erica Mayer at ASCO this year, presented a study in early stage high-risk hormone receptor positive breast cancer where they dose escalated the dose of abemaciclib. They started all the patients on 50 milligrams twice a day. If they were doing well for 2 weeks, then they upped it to 100 milligrams twice a day. They were doing well in that. Then they increased it to the full dose, which was 150 milligrams twice a day. And what they found was that that we were able to keep more patients on the medication doing it this way. We were able to dose escalate most patients, and patients reported less side effects this way than if they started at the full whopping dose of 150 milligrams. So this is a a really nice strategy. I will say in early stage breast cancer, it's very hard to just prescribe 50 milligrams for 2 weeks and then 100 milligrams for 2 weeks and then 150. That's a lot, and your insurance gets confused. I start most patients in the early stage setting on 100 milligrams twice a day of abemaciclib. Now, that is not guideline driven, so don't go to your doctor and say, this is what Dr. Sammons said, this is in the guidelines. That is just what I do because I know that the outcomes are the same and that it's better tolerated. So the bottom line is, if you're having a lot of side effects, you have to talk to your medical team. And just because dose reductions are less common in early stage breast cancer doesn't mean that they can't or shouldn't happen. Certainly if it's CDK4/6 inhibitors, very comfortable with the dose reduction. Chemotherapy, if you need a dose reduction, you need a dose reduction. We do try to maximize, supportive care before dose reducing, but if you need one, you need one. And we'd rather you actually finish the chemotherapy with a dose reduction than not finish it at all or end up in the hospital. So, dose reductions are okay. Your care team will know the potential risks and benefits for you so that you can land on a right dose. I did see earlier in the chat, I'm not looking at the chat until the end, but I saw a lot of patients saying, I have a lot of side effects from my endocrine therapy, maybe my aromatase inhibitor, maybe your letrozole, your anastrozole, your exemestane. Sadly, there's one dose of all of those drugs. And we really don't have data with less. Now, there is some data for tamoxifen lower doses, and there's actually an ongoing phase 3 trial for early stage patients with hormone receptor positive, HER2 negative stage 1 breast cancer, looking at 5 milligrams of tamoxifen versus 20 milligrams of tamoxifen. So we will have some data there soon. We have data in the pre-breast cancer space that 5 milligrams is probably enough. But we sadly do not have any aromatase inhibitor lower dose trials. So how about outcomes in metastatic breast cancer? So when we're thinking about outcomes in metastatic breast cancer, we're thinking more about progression-free survival, the time until the cancer grows, and how long people live. And we have very good data, and I'm going to move a little quicker because I think I'm on the slower end, that dose reductions for CDK4/6 inhibitors, including palbociclib, ribociclib, and abemaciclib, do not impact progression-free survival or overall survival. And so we do, if a patient is having side effects, I feel very comfortable reducing the doses of those. Recently, last week, this study came out. It was the Amelie study that looked at starting patients on ribociclib 400 versus 600. Interestingly, and this was about 360 patients or so, the progression-free survival, meaning the amount of time until cancer grew, was the exact same with 400 versus 600. So was the overall survival. I will say the response rate, meaning how much of the breast cancer shrunk, was very slightly less, 5% less with 600 milligrams, with 400 milligrams compared to 600. So based on this study, I mean, I still start my young and very healthy, robust patients at 600 and then reduce based on that. But my older patients, I generally start at 400, and I think we have very good data to support that. We also have a capecitabine study that looked at 1,500 milligrams twice a day, 1 week on or 1 week off, versus standard dose, which is higher than that, 2 weeks on and 2 weeks off. And we saw very similar outcomes as well. I will say that we don't have, and the side effect profile with the lower dose of capecitabine was much better. Less diarrhea, less hand, foot, meaning rash on the hands and feet. I will say, and we should really petition the companies to do this, I have not seen any dose reduction efficacy data within HER2 and the other ADCs, and I would really like to see that because I think ADCs are very hard to tolerate, and we'd love to have data showing that dose reduction still leads to the same outcomes. So to conclude, oncology drug development previously relied on the maximum tolerated dose, which was not a patient-friendly way to study drugs. And Project Optimus by the FDA has required companies to study lower doses below the MTD, which is good. Dose reductions do not impact outcomes for CDK4/6 inhibitors, palbociclib, abemaciclib, ribociclib, and so feel very comfortable dose reducing there. And same with abemaciclib in the early stage setting. We really need to encourage pharmaceutical companies to show us, dose reduction and efficacy data for all of the drugs, because quality of life and side effects matter. And there's ways to help manage quality of life and side effects outside of dose reductions, which we really didn't talk about today. But dose reductions are a very, very effective way to manage side effects. And one size fitting all dosing is hard to justify and just not right for everyone.
Thank you so much, Dr. Sammons. That was such a nice and concise presentation on such a wildly massive topic that is so, so important. So I really appreciate it. And I know we have so many questions for you. There's lots of things in our Q&A that I know we will try to get to as many as possible. Before we do that, though, I would love to bring our patient advocate, Janice, back on. Janice, if you don't mind introducing yourself, telling us a little bit more about your work. Obviously, Dr. Sammons started to explain Project Optimus and PCDI, but we would love to hear it from you, and then we can hit some of these questions.
Great. Thank you, Caroline. And thanks so much for inviting me to be here today. I have been living with metastatic triple negative breast cancer, as you mentioned earlier, since 2016. Very fortunate to have no evidence of disease for almost 9 years. PCDI is a patient-founded, patient-led organization. We're a nonprofit. And basically, the reason it was founded by Ann Lozier, who was an incredibly brilliant patient advocate back in 2019, is she saw the toxicities and all of the fallout that was happening from these high doses and these toxicities that are side effects from treatments for people with metastatic breast cancer. So she founded PCDI in 2019. And basically, our mission and vision is we advocate for a more balanced approach to cancer treatment, where both the effectiveness of the therapy and the patient's quality of life are considered. And part of that is, looking at early phase clinical trials, as Dr. Sammons already talked about, where historically, they are designed to find the maximum tolerated dose. And as she also pointed out, one size does not fit all. There may be multiple reasons why patients have difficulty tolerating oncology drugs. Those could be due to comorbidities. It may be the way they metabolize the drugs. There are just so many reasons why one size fits all does not work. So when Ann founded PCDI, the Patient Centered Dosing Initiative, in 2019, her first mode of action was to do a patient survey, which Dr. Sammons also talked about a little bit earlier. We had 1,221 metastatic breast cancer patients who responded to that. And what we found is when we followed that up with an oncologist survey the following year in 2021, was that the perception between how many patients were having really significant or bad side effects was different. The oncologist looked at what they believed were patients, the incidence of having severe side effects. And while 66% of the patients said that their treatment side effects, they had reported them to their oncologist, 83% of those patients felt better with a dose reduction. So 87% of oncologists indicated that they started patients at a lower dose for various reasons. And they also were very willing to have these discussions about getting creative with dosing. Dose reductions can be, like she said, like Dr. Sammons said, the schedule, the dose that you're taking. And there are a lot of ways to look at that. One of the most important things I think that Ann always spoke about was the importance that patients, especially those who are on an oral medication, do not change their dose or their frequency or their schedule without first having that conversation with their oncologist. That is incredibly important. For those who are on IV therapy, it's a little bit different. We don't have as much control over that. But for those with oral medications, always speak to your oncologist. And so what we've continued to do, unfortunately, Anne passed away from metastatic breast cancer and GI complications in October of 2023. So it's been just 2 years ago. And we are continuing her legacy. PCDI is made up of members who are all living with metastatic breast cancer. As Dr. Sammons reported earlier in one of her slides, we did an antibody drug conjugate, which is the ADC study for those who are living with metastatic breast cancer earlier this year. And those were reported out. We had a poster at the MASC annual meeting in June. And then we also opened a dosing study for those living with metastatic breast cancer for regardless of what treatment you're on. And that one is reopened now. We did close it to get some data analysis, and it is reopened. So if you have not taken our metastatic breast cancer patient dosing survey, please email surveys@therightdose.org to request to get a link for that survey. And we have already submitted an abstract for the San Antonio Breast Cancer Symposium in December of 2025, and we will have a poster there. So we will be presenting that. But basically, PCDI's mission is just to look at the individuals, look at dose optimization for individuals, because we know that patients who are living with metastatic breast cancer are basically going to be on treatment for life. And those toxicities add up over time. And the toxicities vary from one person to another, the side effects, how they're dealt with. One thing that's very important that Dr. Sammons also said is always report your side effects to your oncologist. They can't help you if you don't tell them how you're feeling and what's going on. No matter how minimal you think they might be, there may be a way to minimize those side effects. You might be able to get palliative care on board, and they can help you manage the symptoms of disease and the side effects from treatment. And one of the things that we really are so proud of at PCDI is Anne presented our patient survey at the ASCO annual meeting in 2021. And it was soon after that that FDA created Project Optimus, which looks at new drugs in a range of doses, because we should have a range of doses that are available, as well as Project Renewal, which looks at drugs that are already FDA approved. And hopefully we're going back, like some of these studies that Dr. Sammons talked about today, these drugs are already approved. So we can go back and look at them and look at the data and see, compare that efficacy at different doses, as well as the side effect profiles. So we really want to encourage industry to do that, trial investigators to really look at the efficacy and a range of doses in early phase clinical trial studies. One of the things we're most proud of is soon after Anne presented at ASCO 21 at the annual Friends of Cancer meeting, Dr. Atik Rahman actually made a statement and said it's loud and clear from our patients that the drugs are too toxic. So as we work towards personalized medicine in oncology, it is vitally important that we find drugs that we can stay on for longer periods of time, drugs that are effective and that we can stay on because the toxicities are reduced. It's really a win-win situation. It's a win for the patients who need those drugs to treat their cancer. It's also a win for the pharmaceutical manufacturers because patients will stay on their drugs longer. So anything that we also have some dose reduction studies that are on our website at therightdose.org. So please feel free to check that out. If you don't really know how to start that conversation with your oncologist about side effects, about what your options might be for dose reductions, we also have a flyer available. It is a two-sided flyer. We do bring these postcards, so they will be we had them at the LBBC annual Metastatic Breast Cancer Conference, and we'll have them again at San Antonio. But it gives you some tips on how to start that conversation. One side is specifically for patients. The other side is specifically for the healthcare provider, for your oncologist, or speak with your nurse practitioner, your infusion room nurse, anybody that is managing your cancer care. please speak to them about any toxicities that you might be having with relation to your treatment.
Thank you so much, Janice. I think it's so important to hear about the work that you're doing. And it's so hopeful to hear that the work that PCDI, or Patient Centered Dosing Initiative, has done has led to these wide scale changes. And as Dr. Sammons mentioned, we're now seeing trials that are really like the camizestrant trial that AstraZeneca put on, where they really are taking a look at these other doses besides just trying to hit it really high and really hard. I did want to mention, because there was a lot of questions that kind of referred to this, can I go on a lower dose? Can I do this? Can I do that? We only have the data that we have based on the clinical trials that have been run, which is how we get these NCCN guidelines and how we make treatment decisions. So, Janice, to your point, that's what we're trying to look at now with our new trials, and also being reflective about how older trials were structured. But for a lot of these things, we don't have hard concrete data. So just wanted to mention that. But Janice, a quick question for you, and thank you, Dr. Sammons, for hopping back on, because we have lots of questions to discuss. This is a tough one. You might not have an answer, but with the changes in the FDA and HHS, are we concerned about the future of Project Optimus?
I think I can say that I have not heard of that Project Optimus is going anywhere. And so, of course, with change in administration and the major changes that are going on in this administration, I think there's always a fear that there could be a shakeup. I have not heard of any changes. And I will say that even this FDA does seem to be concerned about side effect profiles and safety. And so I'm hopeful that it will continue. But of course, I don't know.
Yeah, it's tricky. Janice, any thoughts on that? Anything you've heard on your end?
I have not heard anything on my end. I think, like Dr. Sammons said, we don't know what we don't know, and only time will tell. I do hope that it does not impact Project Optimus in a negative way, because we really need a more patient-centric approach to oncology care at this point. And I also wanted to make just a very brief point too, where, even though PCDI has been focused mainly on metastatic breast cancer, now that we're looking at trials that are bringing some of these antibody drug conjugates like Trodelvy and Enhertu potentially into the early stage setting, even though they're on these treatments for a finite amount of time, I think this is definitely something that is relevant for all cancer patients, all different types of cancer, as well as all different stages.
Thank you so much. Okay, so for both of you, Janice, I know you're triple negative, so you wouldn't have been on an aromatase inhibitor, but as I'm sure you can both imagine, we have lots and lots of questions about aromatase inhibitors from our early stage or metastatic individuals who have to be on these for a long, long time with some really debilitating side effects. Dr. Sammons, I know you touched on this. Can you just maybe re-summarize kind of the research that's going into this? A lot of people are asking, can I take a week off every now and then? Can I switch up my dose a little bit in order to stay on the medication longer? How do you help coach patients on an AI?
Yeah, absolutely. So first of all, I will say that about 40% of patients don't make all 5 years on an AI because side effects are so severe. So I think even just validation and knowing that you're not alone is really important. One thing I do when my patients are struggling, we have 3 different aromatase inhibitors. We have letrozole and anastrozole and exemestane. Letrozole and anastrozole are the original non-steroidal aromatase inhibitors, and exemestane is steroidal. Doesn't mean it's a steroid. It's just the differences in the structure of the compound. For whatever reason, about 30% of the time when you switch a patient from one AI to another, their side effects improve. So if that's not a strategy that you've taken, it is something that I would consider. All of the aromatase inhibitors have similar efficacy. One is not better than the other. And for whatever reason, some people just tend to tolerate one aromatase inhibitor better than the other. And so I would talk to your doctor about, switching if you have not, because the reality is there is only one dose of all of the aromatase inhibitors. And so you can't really dose reduce an aromatase inhibitor. Now, if I have a lower risk patient and they're miserable on the aromatase inhibitors and they're postmenopausal or, even premenopausal, and, switching to tamoxifen is also reasonable. We have different side effect profiles kind of each that you can discuss with your doctor, but tamoxifen definitely has less joint pain. There are some other small, risks with tamoxifen, but switching to tamoxifen is possible too. And then I would just also say that there's a lot of future hope. So there is phase 3 trials going on looking at lower doses of tamoxifen. There's also phase 3 trials going on looking at oral selective estrogen downregulators, so oral forms of tamoxifen, which have much less joint pain. I'm a little worried that they're not going to be better than the aromatase inhibitors in preventing recurrence, but I do think that they will be better tolerated. And they're in phase 3 trials right now. And even one is fully enrolled, and we should see, data in the next few years. And so I think we will have other endocrine therapies other than AIs and tamoxifen in the next 5, certainly 10 years, but it is a challenge.
Thank you for explaining that. I know, this is a constant struggle, and someone said it so nicely. You can't just, it's hard sometimes when doctors are just saying, yep, take this for 5 years. This is what you need, and not really understanding what that 5 years might feel like for someone. And so I think exactly as you said, advocating for yourself, potentially talking about a switch in medication if that's indicated for you. But also just sometimes it's helpful to just know that doctors and researchers are thinking about this and trying to make it better, even if it's not in the immediate moment. So that's really helpful.
There's also a lot of
yeah.
ways that, patients can support themselves on aromatase inhibitors. Acupuncture, exercise, tart cherry juice are all things that have been shown to improve joint pain, hot flashes. So there's a lot of supports too, but it's even with that, it's hard.
Absolutely. Absolutely. Those are great recommendations though. And I know, as you said, being on the drug, and even if it does have to be modified in some capacity, is better than not being on it at all. Question from someone. So this is, and maybe both of you have some thoughts on this. Is it better to reduce the dose or change the cadence? And I know that, those things are kind of the same. Cadence is dosing, but would you accept, so their example is, 3 weeks on, 1 week off versus 3 weeks on, 2 weeks off, or getting an actual dose reduction and staying on the typical cadence. Any thoughts there?
Yeah. So I think, I generally recommend taking the drug in the way it was studied, just because if a patient does not have the outcome that we hoped for taking the drug and they weren't taking it in the right dosing, I don't know if that's because they weren't taking it in the right cadence, or if it's because, their disease truly became resistant to it. And so I prefer to stay at the same cadence. That means, if it's studied 3 weeks on, 1 week off, I would stay there and I would reduce the dose, because we do have data with reducing the dose, right? But we don't have data with changing the cadence. And so I would rather reduce the dose than change the cadence.
Super helpful. Thank you. I think that's great guidance. A couple other comments talking about taking age into account. Our older population sometimes has more adverse effects from these really tough medications. Is there research into age starting at a lower dose? What are your thoughts?
Yeah, great question. So you're absolutely right. And I will actually say that older patients are very underrepresented in clinical trials. So that's number one. The clinical trials that do study age related to side effects, let's just talk about the CDK4/6 inhibitors. They do show that patients that are older have more side effects. Therapy. There is actually the first trial that ASCO is running is a trial for breast cancer patients that are older than 65, looking at starting them on a lower dose of a CDK4/6 inhibitor versus full dose. There's also an ongoing national trial in early stage breast cancer looking at starting Taxotere Cytoxan at lower doses for women older than 65 versus standard. And so there is some ongoing work, but there definitely should be more.
That's a tough one. Janice, anything that PCDI has done with regards to age?
The only thing I am, as you mentioned earlier, the patient advocate lead on the ASCO CDK4/6 dosing study for people 65 and older. And I think that will be, it's a pragmatic trial. It is not a prospective trial, meaning there's not any new drugs that are being studied. There are existing drugs, and we've got the two arms where some patients will be randomized to start at the recommended starting dose, whereas other ones will start at the lower dose. And they'll do what's called titrate up, meaning they'll increase the dose as needed or if tolerated. So I think that will be a really interesting study to see. They are still in the process of accruing for that. So I think that will be some good data. I don't know of any other specific studies other than that one that are going on right now. But I do see that, it is even with younger people sometimes, sometimes the lower dose will work just as well. And they'll have fewer side effects. I think that's really a very individualized thing. But I think in particular with older adults, like Dr. Sammons mentioned, we are very much, and I'm in that category, we're very much underrepresented in clinical trials, usually excluded.
That is really tough. Well, I'm glad that there is some work being done on this because I think it is super important. And I know, depending on your oncologist, that can be a discussion when you start your next line of treatment. Is the full dose going to be right for me? If you have comorbidities or other things going on in your body, I know we would sometimes make the decision like, hey, we're actually not going to start you on the full dose. So I think having that open and honest conversation, even if we don't have clear-cut data, is really important. Another really great question. So for individuals living long-term, which we see, and it's incredible with MBC, Janice is an amazing example of that. Are there studies out there about what the long-term effects are of being on some of these toxic medications? This person in particular gives the example of Herceptin, Perjeta, and an AI. And they've been on it for 6.5 years. So are there kind of longevity surveys of these medications? And if not, how can they get that to happen?
Yeah, that's a really good question. I think there's definitely data out there, particularly on Herceptin and Perjeta, just single institutional or multi-institutional retrospective studies looking at safety. We do not have that for every drug, and it would be great for patients and physicians to advocate for not only reporting the side effects when things first come out, but doing a 3-year, 5-year side effect update. The reality is on clinical trials, they don't collect side effects for that long. And so this would have to be real world analysis. But that is something that we should be doing. I will just say specifically to that patient, we have a study ongoing for patients who have been NED on Herceptin and Perjeta with metastatic breast cancer for over 3 years. That's looking at stopping and what of some of those patients might actually be cured. And that will be presented probably this year at ASCO.
That is awesome, and actually answers what someone else had asked about. How long do I need to be on these drugs? So that's very, very helpful. Okay.
And then I will also just say for all of the advocates and foundations out there, these are the types of studies we need to fund. Industry is not going to fund a study stopping a drug. So these are where NCI funding comes in, patient advocacy foundation funding comes in.
Mm-hmm. No, I think that's so important. It's a great call to action, because you're right. Pharma, that's not
They're
what they're
great.
looking to
Pharma's
do.
great, and we need them, but
We do.
they have bottom lines.
Absolutely. We have a couple individuals, and we've mentioned these ADCs or antibody drug conjugates. So, for those who may be less familiar, those are more targeted chemotherapies. We always describe them as a heat-seeking missile. Drugs like Enhertu, drugs like Trodelvy, drugs like Datroway, which have been approved in the metastatic setting. They're creeping into early stage as well. They can be really hard to tolerate. And Janice, you mentioned this. Dr. Sammons, you mentioned this. Having some brutal side effects within HER2, which I had seen in my practice many, many times. What are those dose reductions like? I mean, I know we don't have data on them, but what's that feasibility? And then one person actually mentions being overweight as well. So maybe you could talk a little bit about ideal body weight dosing, if we use that in HER2. Have at it.
Yeah, so we generally don't use ideal body weight dosing. We use BSA and mg per meter squared dosing. Many patients on Enhertu need a dose reduction. I will also say, and I don't know, please comment in the crowd if you feel the same way, but a lot of my patients feel like the first 2 to 3 doses of Enhertu hit them hard, and then they kind of get used to it. So I try not to do a super early dose reduction unless the patient is, really, really doing terribly, just because I do find that things get better. Sometimes they don't get better. And dose reductions can be very helpful for fatigue. They can be very helpful there's a lot of nausea to this regimen, and you want to make sure that your team is giving you 3 drugs with the infusion. And then I generally give my patients a few days of steroids after the infusion, which helps really well. Some patients have side effects to the steroids too, and then you have to take them off or reduce them. So it's, you just got to have a team that's willing to work with you, because it's so patient dependent. But reducing the dose is often needed. We don't have data on the impact of efficacy with ADCs, but if you need to reduce the dose, I'd rather you reduce it. I'd rather reduce it and keep you on it than just have you go to something different.
That's really, really helpful. Thank you for explaining that. Another person was asking about med holidays. I know I've talked with oncologists about this a lot. Would you consider a med holiday a dose reduction?
Would I consider a med holiday a dose reduction? I would not consider a med holiday a dose reduction per se. I would consider it a holiday.
I think that's a very fair answer. And again, we don't have data on that kind of stuff, unfortunately, but it can be really beneficial. So something to keep in the
I just
back.
see someone, and HER2 is weight-based. It's just based on milligrams per meter squared and not ideal body surface area, which was the question.
Yes, thank you for that. Where are we? And this is broad, and you have mentioned this somewhat, but where are we in kind of going more towards that personalized medicine, that individualized dosing, and kind of sorting out what might work best for someone, especially if you're hypersensitive to some of these medications, as opposed to just going through kind of this more standard blanket dosing?
Potentially not so close, just because,
Okay.
I mean, with chemotherapy, it is generally weight-based. It's the oral drugs that are not so weight-based. The only oral drug that's weight-based is capecitabine. But, for CDK4/6 inhibitors, for PIK3CA inhibitors, that's where it's really not weight-based. It's just starting at a flat dose. And so that's where we probably, with the oral drugs, is probably where we should get a little bit more elegant in terms of our dosing strategies. I think that it would be a lot more challenging, and it would probably stifle the ability to quickly do a clinical trial and get a drug to market if we were doing sort of more elegant weight-based strategies. But it's still something that we should continue to troubleshoot and advocate for. And, we can do that.
That's great and really helpful. Janice, anything, I know, obviously, Dr. Sammons, you've done such a beautiful job of answering these questions. Janice, any other suggestions or feedback for people either early stage or metastatic who may really be struggling, and how would you advise?
I think it's already been said, please have that conversation with your entire oncology team, whomever you're seeing, whether it's a nurse practitioner, a PA, your infusion room nurse, your oncologist, all of them. Keep a journal. At least that worked for me. Keep a journal of what side effects you're having, because when you get into your appointment, the chances of you remembering 2 weeks ago that you felt really bad, or you had these symptoms. So keep a journal. There are a lot of platforms out there too where you can actually input side effects, online into a platform, and then you could just print it out or pull it up when you're in the office. So always have those conversations with your oncology providers. I think too, especially in the metastatic setting, because about 80% of us in the US are seen in community oncology settings. If for some reasons something doesn't feel right, or even if it does, and you have a generalist as your oncologist, consider getting a second opinion, or you could be like me and get 4 of them. I mean, there's never too many. I just think that, because I think the quality of care that we receive really impacts our life especially in the metastatic setting, but even in early stage, I also got second opinions from every single provider. I think that is, if you can do it, I think that is a very important thing to do, especially in the metastatic setting, to at least just have someone on your team. If you have progression of disease, if you're changing treatments, maybe you're not sure about whether the treatment plan is the right one or the best one for you, you have somebody you can fall back on who is an expert like Dr. Sammons in breast cancer. And, it's the difference between seeing patients with all different types of cancers versus having that focus on breast cancer alone. So that's probably my highest recommendation.
That is such a good recommendation. And you're right. Being able to find those second opinions with someone who just treats breast cancer and can really keep their nose to the grindstone of the research is so important. Write things down. I always say take a friend or a partner with you. So many times patients would come in and their friend would be like, "What are you talking about? You're fine. You haven't gotten out of bed." And that's what we need to hear as a care team. So I think all of those are great suggestions. Dr. Sammons, any other final notes from you for this amazing crew who's here today?
No, very engaged crew. I talk to your teams, particularly with oral medications. Oftentimes dose reductions don't impact outcomes, but they can make your quality of life immensely better.
Mm-hmm.
And so don't suffer in silence. Talk to your team and keep advocating, because I think Project Optimus is a result of hearing the patient voice. And so keep doing your thing, advocating out there. And until next time.
Amazing. Well, thank you so much, Dr. Sammons and Janice, for sharing your expertise. I know we all benefited greatly. I learned a ton myself from the information that you both shared.